Colorectal carcinoma is a malignant tumor of the large intestine. It's the third most common cancer in both men and women, and is the fourth most common cause of cancer-related deaths worldwide. This cancer kills approximately 700,000 people annually. Anatomy. The large intestine is about 1.5 meters in length. It comprises the cecum, appendix, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. The large intestine starts in the right iliac region of the pelvis, where it's attached to the small intestine at the ileocecal junction. Transverse colon makes sharp angles in both upper quadrants. The one on the right is known as the hepatic flexure, and the one on the left is known as the splenic flexure. On the surface of the large intestine, there are three bands of muscle fibers that run longitudinally, called tennae coli. They start at the base of the appendix and extend from the cecum to the rectum. The tennae coli contract to shorten the walls of the large bowel, producing distinct, incomplete pouch-like structures known as haustra. Arterial supply to the large intestines is from the branches of superior and inferior mesenteric arteries. Adenocarcinoma is the most common form of colorectal cancer, which accounts for greater than 95% of all colorectal cancers. Pathophysiology. The word adenocarcinoma is made up of two words, adenoma and carcinoma. Adenoma means a tumor formed from glandular structures in the epithelial layer. The intestinal epithelium is the layer of cells that forms the luminal surface or the inner lining of the colon. Carcinoma means cancer. A tumor simply means a group of cells which forms a lump or abnormal growth. A tumor can be cancerous, aka malignant, or non-cancerous, aka benign. Adenocarcinoma of the colon develops from the adenomatous polyps that undergo dysplastic changes to become cancerous. The word polyp is used to describe any protrusion of the mucosa. These polyps are thus small groups of tissue which arise from the walls of the colon. Polyps can grow in other parts of the body as well. Polyps can occur as a solitary growth, as a group of few, or as a part of a polyposis syndrome. Majority of adenomatous polyps develop mainly in two distinct shapes, and they are frequently classified according to their shape: sessile and pedunculated. Sessile polyps grow flat on the mucosa and thus can be difficult to visualize on colonoscopy. Sessile polyps are considered precancerous. Pedunculated polyps grow on a stalk, like a fruit hanging from the branch of a tree. Adenomatous polyps can also be classified histologically: tubular polyps that seem to have holes or tubes under the microscope, villous polyps that look like a branching tree, tubulovillous, which is combination of the two above. Serrated polyps have sawtooth appearance under microscope. You can see that the one on your left is pedunculated, as it has a stalk, and the one on the right is sessile, that is growing flat on the surface of the mucosa. Risk factors: polyps, family history of colon cancer, inflammatory bowel syndrome, Crohn's disease, sedentary lifestyle, processed food, red meat, especially partially cooked red meat, obesity, smoking, alcohol, genetic factors, and aging. The risk of turning an adenomatous polyp into a cancer increases with their size. Tubular adenomas with a diameter of 1 centimeter carry a 10% risk. Villous adenomas with a diameter of greater than 2 centimeters carry a risk of 15%. Signs and symptoms: many polyps can take a long time to turn into a cancer, and many early-stage colon cancers do not cause any symptoms at all. Frequently, such cancers are diagnosed when they have spread into the other parts of the body. Villous tumors can cause diarrhea, mucus discharge, and occasionally hypokalemia. Weight loss and anemia may be the first symptoms. Various methods of colon cancer screening are available to find polyps or cancer at a time when it is not too late. Symptoms may include blood in the stool or rectal bleeding, anemia, abdominal pain, cramps or flatulence, fatigue, changes in bowel habits such as diarrhea, constipation, and bloating. 20% of patients presenting with intestinal obstruction are diagnosed with colon cancer. Diagnosis. Colonoscopy is a common examination which involves the use of a colonoscope, such as the one shown in the image. The colonoscope is inserted through the anus into the rectum and the colon. The camera at the end of the colonoscope is able to take images of the large intestine from inside. Polyps, if found, may be removed for histology, as well as to decrease the chances of them turning into malignant tumors in the future. Double contrast barium enema is a radiology procedure of the large intestine, which is able to diagnose abnormal growths and large polyps. An image from one such study is in front of you, showing 2 polyps. Abdominal and pelvic CT and MRI. Both these modalities have become very popular in recent years and are very helpful. CT is frequently performed for staging of the cancer. CT can find if the cancer has metastasized. In other words, if it has spread into the other parts of the body. PET-CT. Positron emission tomography is a type of nuclear medicine scan in which a radioactive material is injected and then images are acquired with the help of a special machine. PET-CT combines images from PET and CT scans to detect cancerous growths and determine metastatic spread. Treatment. Treatment depends upon histology and staging results. If possible, tumor is surgically removed. Surgery is often followed by chemotherapy. An image of part of the resected colon is in front of you. This is a cross-section of part of the colon, which shows normal mucosa, several polyps, and a cancerous growth. In many cases, chemotherapy is also used as a treatment and is frequently combined with radiation therapy. Main purpose of the chemotherapy is to decrease the chances of cancer spreading into other parts of the body. Both of these treatments can have severe side effects.